Hello, everyone. Welcome back to our NCLEX review session. And if you're just joining us, today marks the 8th day of our 90-day free NCLEX review classes, which we hold daily at 12 p.m. Eastern Standard Time. And we are covering all nursing subjects and provide explanations for 2000 NCLEX style questions. And today's focus will be on the nursing care and management of an adult patient with autosomal dominant polycystic kidney disease and also the hydronephrosis, and this will be followed by a Q&A session. So just sit back and get ready with your pen and notebook as we go along these topics. So first things first, I really want to promote our review classes through the YouTube channel, and we are on the 8th day of our session. And so this will last for about 90 days. And so these classes are free, and I really want you to invite your friends trying to review and pass the NCLEX so they can get the benefits and also the perks that we are offering. Again, we're doing this live every day at 12 p.m. Eastern Standard Time, and I really don't want you to miss this. So I want you to hit the subscribe and like button and share this in your social media. I want to make sure that you can also enjoy all our lectures. Now, we're going to cover those nursing concepts from med-surg, maternity nursing, psychiatric nursing, and pretty much all the nursing subjects that will be asked in the NCLEX. So again, I want you to share this to your friends who are studying for the NCLEX. And again, I want you to check for the information in the description box below so you can get all the information there as well. And another thing that we are offering is the course that we have posted into the website, www.stancoastnclexcoaching.com. Again, that is www.stancoastnclexcoaching.com. And we do have here the NCLEX course, and we are offering about 70% discount for this month only. And this will include about 3,000 NCLEX style questions and whopping 5,000 brainstorming nursing questions as well. And if you need a quick refresher, we've got you covered because we have the OD book, and also we do have 100 hours of thorough NCLEX prep. And also we're going to have some extensive library of on-demand videos, and we also have mock tests and also different test series. And this is going to be accessible for about 6 months with your subscription that you can access 24/7. So that's it. Now get started with the first topic that we have for today, and this is on the polycystic kidney disease. Now, we are going to talk about the adult version of this disorder because we know that polycystic kidney disease can also occur in children. And so we're going to actually talk on the autosomal dominant polycystic kidney disease, or known as the ADPKD. All right, we'll just shorten that because that is quite long of a disease name. So the disorder itself basically is going to involve the formation of numerous cysts in the kidneys, and this will lead to their enlargement. Now, the bad news is that the cysts can actually rupture and they become infected, and this will develop into different scars and ultimately will cause the damage to the nephrons, which are pretty much the functional units of the kidneys. Now, the PKD can lead to cysts forming in the liver as well, and also other tissues and body organs, including the brain, also the blood vessels, and the heart. And so it's just not isolated to the kidneys, but it can also cause damages to the other major organs. Now, at this time, there is no targeted therapy that will stop the growth and the development of the cyst in the PKD. However, though, the management here will focus on controlling the symptoms and also slowing the disease progression, and to also address the complications such as hypertension and kidney failure, because this is what we don't want into our patient. We want to slow down the progress in order that they can avoid all these worse complications that we can think of. Now, the complications of the ADPKD are the following. One is the ESRD, which is the end-stage renal disease, because over time, the damage caused by the PKD can lead to this problem, wherein the kidneys will gradually lose their ability to function. Again, this is not going to develop right to the end-stage renal disease. It will go to from an early phase wherein you can still manage the symptoms and there's not a whole lot of complications that can occur at that point. And so early diagnostic testing is very important in the care of this patient. Now, again, this can really lead to end-stage renal disease and can also require dialysis or possibly transplantation of a new kidney for the patient to survive. Now, another complication that this disorder can do is actually the heart valve prolapse, because the PKD can also affect the connective tissue, especially the heart valves. And this is going to lead into the mitral valve prolapse. And if you recall, the problem with the mitral valve prolapse is that it can cause regurgitation of the blood from the left ventricle into the left atrium and backing up into the lungs, which can cause pulmonary edema. And of course, with the mitral valve prolapse occurring over time, this can lead into left-sided congestive heart failure. Now, another complication that we know about in PKD is the brain or berry aneurysms. Please take note of that name there, berry aneurysms, because of the cysts they're actually forming. And also, it can lead into the bursting of those blood vessels because of the hypertension that can develop. And this is really a known risk factor for the development of the cerebral aneurysms. Now, we know that the blood pressure is going to be higher this time, and also with the stress on the blood vessels, this can make the cerebral blood vessels susceptible for weakening and also the ballooning or bulging of these cerebral blood vessels. Isn't that scary? That when your patient only had presentation, let's say renal presentations, and all of a sudden they just went into coma because of an aneurysm. Now, another complication that we have known in the literature is the hepatomegaly, the enlargement of the liver, and also an accompanying fibrosis, because the PKD, or the same mechanism that affects the kidneys, can also cause formation of cysts to form in the liver, which is pretty much similar to the kidneys. Now, the liver cysts are actually or usually benign and don't always cause symptoms. However, though, in some cases, they can grow large enough to cause discomfort and can also lead to abdominal fullness and complications such as hepatomegaly or maybe impairment in the function as well. There will be elevation of the liver function tests and enzymes. Now, with a fibrosis, that simply means that there will be scarring of the liver tissue, which simply means that it will not be able to function anymore. I mean, the healthy portion of the kidneys can regrow, but for those scarred tissues are no longer functional. All right. Now, the symptoms for this patient with the hepatomegaly will be about fatigue. They're going to be developing jaundice, which is the yellowing of the skin or the eyes, and there will be abdominal complications and also liver failure. Now, we really don't want to get to that point where our patient is dealing with too many complications. Now, the next complication that we know of is splenomegaly. Basically, the spleen will develop these cysts, and they are typically kind of smaller, and the incidence of the splenomegaly or the incidence of the cyst here is somewhat kind of rare, and sometimes patients can be asymptomatic and may not require treatment. However, though, with a larger splenic cyst, they might cause discomfort or may have some complications such as splenic rupture, wherein the person will end up bleeding profusely, and also some infection. And so these are the things that we need to keep an eye on before everything gets way out of hand. Now, another complication here is the pancreatitis, of course. Well, this is somewhat kind of like less common than the kidney or liver cyst. However, if the pancreas has been invaded by the cyst, then of course, this can also lead to the condition called pancreatitis. And it's no joke. When there is autodigestion of the pancreas, this can also lead to diabetes mellitus, which is pretty much like you need to manage the person with the insulin to make sure that they're not going to end up with way too much of the blood sugar, right? And also they're going to be dealt with accordingly with the severe abdominal pain. I mean, I've dealt with so many acute and chronic pancreatitic patients. They are in a lot of pain. And most of them are not going to be allowed to take any food or drink. They're going to be placed on NPO for maybe 2-3 days until the inflammation subsides. And this is no fun at all when they're going to develop some cyst in their pancreas. Now, let's go ahead and talk about the different types of the polycystic kidney disease. So basically here, we're just going to split this into two different types, which is the first one, the autosomal dominant PKD, which is pretty much like isolated to the adult population, and this is hereditary. And so again, this is inherited in an autosomal dominant pattern. It simply means that if one parent carries the defective gene, there is a 50% chance of passing it to one or each child. Imagine that. There's a 50% chance of passing it to each child. Now, for the onset here, this is something that can start in childhood. I mean, just the development of the cyst because of the inheriting the change gene. But the signs here will not show up until adulthood, usually about 30 and 40 years old. However, though, the age symptoms begin and how severe they are can vary in a lot of different people. And so please take note, guys, that the adult PKD or the autosomal dominant PKD has about an incidence of at least 1 in 400 to 1,000 individuals, so making it one of the most common inherited disorders affecting the kidneys. And it has a mortality rate of at least 20 to 50% over a 2-year period. So most of the time, if the person did not seek any medical treatment, probably by the time when they're diagnosed, it's already on the late stage. And so, yeah, that's kind of disheartening when they will not be able to really help to prevent the progression if this is a time that they will now require the kidney transplant or maybe dialysis, which is not really going to cure. And so this will really underscore the seriousness of the condition and also the need for effective management and treatment. Now, as far as the life expectancy, even with better treatments, people with the autosomal dominant polycystic kidney disease don't live as long as others, and typically between 53 and 70 years. So catching it early on and also providing thorough care is really important for better results. Now, talking about the second type here, which we are not going to discuss this time because we are dealing with med-surg. And so the second type here is the autosomal recessive PKD. And this is an inherited autosomal recessive manner, meaning that both parents must carry the defective gene for a child to inherit the condition. So it is relatively rare compared to the ADPKD. Now, as far as the onset of the ADPKD, this will typically develop during the infancy or even during pregnancy, and this can lead to complications after birth. Now, at this point, we're going to talk about the different etiology and the mechanisms for the PKD. And so this is going to be caused by the changes in the certain genes that will control the kidney function. And so These changes can be inherited from one parent and are linked to three main types of mutations. So again, I'm talking now about the autosomal dominant PKD because this is really what we're going to deal with today. And so with the etiology, we're talking about the PKD1 mutation, which is basically going to comprise about 85% of the ADPKD. So pretty much this is going to result into the formation of the fluid-filled cyst. And this mutation is found in the majority of the PKD cases. And this is also going to alter a gene called the PKD1, which is again going to lead to the formation of the fluid-filled sacs or the cyst in the kidneys. And so with this kind of mutation, this can grow over time and it can damage the kidney tissue and also the function. Now, talking about the second mutation here, which is the PKD2 mutation, which is going to comprise about 15% of the adult PKD. And this time, this can affect the movement of the calcium in the cells. And I'm just talking about the kidney cells, but actually all the other organs in the body, especially for those sites that I mentioned about the complications. And so this is a mutation that is less common, but is still considered significant because this can also, because the mutation can also affect the movement of the calcium in the kidney cells. And so with that, it can really contribute to the rapid development of the cyst in the kidneys. Now, we're going to talk a little bit of the PKD3 mutation, which is rare, and reviewing in the literature, this kind of mutation is not well established yet. It's not well understood, and so we don't have a lot of literatures to really support this kind of theory. And this is something that, of course, they say would happen less frequently. But yes, because we don't have enough data about this kind of theory. So its role in PKD is unclear, and we still need to have some further research and need to understand how it contributes to the disease. Now, at this point, we are going to talk about the interesting pathophysiology of the adult or the autosomal dominant polycystic kidney disease. So I really want you to hang tight and pay attention. And I want your eyes get peeled into this because this is somewhat kind of like maybe a little bit confusing, but I'll try my best here to explain this simply. Now, I want you to really grasp this because as future nurses, it's very important that you can grasp the complexities of this condition in order that you can provide effective patient care. So I'm not just teaching here just to let you pass the NCLEX. I just want to make sure that this knowledge will be used up until you're going to be professionals and also licensed nurses. All right, that is my goal, not just passing the NCLEX, because sometimes you're just going to think about memorizing and right after you can easily forget those concepts, and that is well tested. And so pay attention really so you can get the most benefit here. So first and foremost, let's dissect the genetic underpinnings of the ADPKD. So this condition can arise from the mutations in the three key genes. So we have the PKD1 and also which is going to cause disruption in the function of the polycystin 1. Now we also have the mutation in PKD2, which is going to cause dysfunction in the polycystin 2 channels. And again, I already mentioned this in the previous slide. And then we have the PKD3, which is quite unknown yet. This is quite ambiguous. And altogether, these three mutations altogether will cause the dysfunction of the channel, especially the calcium channel on the epithelial cells. So this is kind of fascinating how these mutations can actually converge on a very common pathway, which is really disrupting the calcium signaling. Now, with that, this can now cause the different issues, especially Now, before we go ahead into the different disruptions into the different organs in the body, we'll talk about the polycystin 1. So what is the function of the polycystin 1? Because this is really a necessary piece of information in order that you will be able to understand why, if there is dysfunction, why it can lead to the intracellular calcium signaling. Well, the polycystin 1 is actually a protein in the kidney and the other organs in the body that can help the cells to communicate and stick together. So it also will sense the changes in the fluid flow in the kidneys and also the other cells in the body in order to respond to these changes. All right. Now, when the polycystin 1 doesn't work properly due to the mutation, it can now lead to the growth of the cysts in the kidneys and other body organs, which will cause the swelling, collection of these pockets of fluids in the different organ tissues. And also the polycystin 2, which is right here. This is another protein. Let me use my pointer. So that polycystin 2 is another protein in the kidney cells and other organs in the body that will also act like a gate for the calcium ions. So its role basically is to help regulate the calcium levels inside the cells, which is very important for the cell growth and their function. Now, when the polycystin 2 doesn't work properly because of the mutation, it will now contribute to the growth of the cyst in the kidneys and also the other organs in the body. Now, our focus this time is towards the kidney dysfunction, correct? And so this will be our mainstay in our discussion. And so when this happens, there will be an abnormal proliferation and also dysregulation of the fluid secretion. And this will now cause the formation of the numerous cysts throughout the renal parenchyma, okay? So now this is going to cause the cyst to grow in slow progression, okay? Imagine that we are talking about the autosomal dominant PKD. So it doesn't happen rapidly. It can start growing even during the childhood, and the manifestations will only be present when the person reaches middle adulthood in their age in maybe 30 years old to 40 years old. And so this excessive cyst formation will now create a palpable abdominal mass. So again, this is probably going to be detected during the middle adulthood stage. All right, so this is one of the immediate assessment finding that you can see in this patient. Now, probably this is the only trigger that the test will be done because probably the person was asymptomatic. No problem at all. No other manifestations, no other, no oliguria, nothing at all. They're asymptomatic. And so probably this is the only trigger that the medical provider will do some more testing. Now, this presence of the proliferation of these cells and also the pocketing of these fluids in the cyst, it can now precipitate compression of the renal blood vessels, all right? So when this happens, the body will be fooled into thinking that, hey, the kidneys are not getting enough oxygenated blood. It's not getting enough blood supply. So when this happens, it can now trigger the RAS mechanism, and also it can lead to the hypertension. Remember about the RAS mechanism wherein it is going to cause a cascade by allowing the kidney to release the renin when there is a sensation that the kidneys are not getting enough perfusion, or let's say there is a low blood pressure or low circulating fluid volume. So that cascade will be started when the kidneys feel like, hey, I'm not getting enough blood here, so gotta do something about it. And so with the RAS activation, it ends up with the hypertension. Please take note of that. And remember about the effects of the angiotensin 2. It can do both ways. causing direct vasoconstriction of the blood vessels in the body. And the other one is to cause triggering the adrenal cortex to release the aldosterone. And remember that the aldosterone will cause reabsorption of the sodium ions in the renal tubules, and it will also cause reabsorption of water. So there will be an increase in the blood pressure plus an elevation of fluid volume circulating in the bloodstream with hypernatremia. So don't forget about that, because this is a critical element in your critical thinking when you're going to be tested. Now, we're going to talk about the stretching of the renal capsule. When there is now enlargement of the kidney tissue, it will stretch because of the growth of this cyst, and the encapsulating covering will now feel that something is not right. It can lead into the flank pain. So your patient will report this flank pain, and this is non-radiating. This is localized. Okay, please take note of that. Now, another effect with the proliferation of the cystic cells is the stasis of the urine. Please take note of that. Why? Because of the growth, the overgrowth of the cystic cells, it can allow stagnation of the supposedly urine that will be emptied into the calyces, into the ureter, into the bladder. But because of the cysts in the kidney itself, it can cause some trapping, sluggish flow of the urine downwards the urinary tract. And so this is now going to be a conducive environment to allow the precipitation of the calcium oxalate crystals. Now, we're back to the calcium oxalate crystals, which we talked about in our discussion in the renal calculi. So when this happens, this will lead into the development of the renal stones we call the nephrolithiasis or renal calculi. And this is going to be a painful complication, which will be further compounded by the presence of the renal cyst. Remember that it's already painful just by the presence of that enlarging kidney tissue. It can already cause flank pain, plus the presence of the kidney stones. What do you think? You would be in a lot of pain. You're going to be in agony, crying for the pain medication to arrive really shortly when you get admitted. Now, let's explore the intricacies of the convoluted tubule dysfunction, because it can also do that. With the urine stasis, this can also lead into the bacterial growth. And this is going to be, again, the medium for the bacteria to grow faster. And of course, can lead into the pyelonephritis, which we talked in the previous session. And remember about the pyelonephritis, this is the actual infection of the renal parenchyma, and will also lead to flank pain, which is localized, right? So bingo, you got all those leading to flank pain. And if this happened all together, how lucky. Now, with that, we're going to talk about the impairment of the proximal convoluted tubule, wherein there is now a disruption of the acid-base balance, and this is actually going to cause a decrease in the ammonia and also the urine pH, wherein there is going to be a tendency to allow the uric acid stones to grow. And so this is something that can be often overlooked complication with significant clinical implications here. And so with that, this can also lead into the development of the nephrolithiasis. So imagine that there's also calcium oxalate, there's also the uric acid stones. Oh boy, I just don't want to deal with this anymore if I'm the patient, right? Now, we're going to have to talk about another effect of the development of the cysts in the kidneys. This is going to cause the impairment of the collecting duct as well. So at this point, the structures which are called the collecting ducts, they are the distal portion of the nephron, right? Wherein the urine is supposedly going to be emptied into the renal calyces. And so at this point, the collecting ducts will struggle to concentrate the urine. And so what is going to occur here? Well, there will be the decreased urine concentration. So this is something that is not going to help out the patient. If this is going to happen, if the kidney, if the collecting ducts will not be able to concentrate the urine, then that will cause the person to have polyuria, which is excessive excretion of the urine, and also a specific gravity that is way lower than 1.010. So it simply means that the urine is very diluted because the the distal tubules, or let's say the collecting ducts, are not able to concentrate it. And so the problem here is that the person will actually going to end up with volume depletion. They're going to end up being dehydrated because of that issue. And so think about the polyuria and the very dilute urine. So what you're going to expect here when this happens is that there will be very diluted urine in color, of course. So you might expect very light color, straw colored urine. All right. But here's where it gets truly fascinating here. Aside from that, there will be damage to the nephron itself. And this is just not focused on one of the sections in the nephron, but this will also cause problem into the different tubules, the PCT, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, the collecting duct, plus the glomeruli itself. And so this can lead into the proteinuria and hematuria, okay? Please pay attention here, guys, that I'm talking about just a routine, should I say routine, but hematuria that is expected, it's not really visible to the naked eye. It's just that because there is leaking of the red blood cells and also the leaking of the proteins in the glomerulus because of the effect into destruction of the filtration system. So it will not allow these molecules to seep or leak out into the urine. And pay attention here, I'm not talking about the actual rupture. I did not include in the pathophysiology those instances wherein there is going to be a possible rupture of the kidney. I have not included that one yet. So we're only talking about the hematuria that can be noticed microscopically and the proteinuria, okay? So, but we're going to move on here because there's a whole lot of other problems that you're going to encounter here. And so aside from its disruption into the kidney function, it can also affect the other organs in the body, and I'm not going to elaborate on these because this is going to require a different session. And so it will cause problems into the heart valve, especially the mitral valve. It can lead into mitral valve prolapse. And I mentioned that already during the first slide about the complication of a mitral valve prolapse, congestive heart failure, and also pulmonary edema. There's also going to be development of the Berry aneurysms. It can affect the endothelium of the cerebral blood vessels, and of course coupled with a hypertension. And we also have the liver problems. There will be enlargement of the liver and also accompanied by fibrosis, scar tissues. And again, this can also lead into liver failure. There will be elevation of those enzymes. Liver function tests will be skyrocketing. And of course, we know already if there is a problem with the liver, if it's going to end up with, let's say, end-stage liver disease, you don't want to see that patient because they're going to be so confused. Their ammonia levels will elevate. They're going to be comatose at that point. You really don't want to deal with that kind of problem. It's so hard. It's heartbreaking. And we also have some spleen complications. There will be enlargement of the spleen. And if this will rupture, it's no joke. Person's gonna end up bleeding. And also with the pancreatitis, well, of course, you gotta deal with the hyperglycemia. You gotta make sure that the patient's pain is well controlled because this is quite painful. So our focus again here, I want you to pay attention into those red highlights: flank pain, hypertension, pyelonephritis, nephrolithiasis, bacterial growth, proteinuria, hematuria, and polyuria, which I forget to highlight in red or pink. So those are the main highlights in the renal issues before it becomes more complicated, before the patient goes into an end-stage renal disease. So please don't forget these, because these are the things that will be asked in our Q&A. All right? Now let's move on into the assessment findings, my favorite. And so with the ADPKD, again, I said earlier that maybe the patient will be asymptomatic at first until they reach the middle age in the 30s or 40s, and it is going to progress slowly. And when this is going to happen, when the symptoms start to appear, well, of course, it will be manifested by the pain in the flank area, also the lumbar or the abdomen, and this can be worsened with activity and can improve with rest. So that is the kind of pain that the patient will experience, excuse me. And so the pain will result from the growth of the cyst in the kidneys, which again will stretch the renal capsule, right? And it will exert pressure onto the surrounding tissues. Now, because of that, there's going to be a coupling with the infection. And so the patient will also manifest some fever and chills, maybe recurrent urinary tract infections. And because it will also lead into the stasis, right? Remember that with the presence of the cyst, it can cause stagnation of the urine and can also lead to the development of the kidney stones and also the calcium oxalate, or it could be the infection, the growth of the bacteria. That could also probably allow those struvite stones, and those are the most painful type of stones, those staghorn type of stones. And this can also lead to the hematuria, remember, because of possibly now maybe the stone is eroding into the, what do you call this? The renal tissues, or maybe eroding into the tiny passageways like the ureter. It might lead into a visible blood tinge, or if it's not happening yet, maybe the hematuria can only be seen through the microscope, through the leaking of the red blood cells in the glomerulus. Now, there's also proteinuria. Like I've said, this is because of the dysfunction in the glomerulus and also the tubules. So this will now allow the proteins to leak out into the urine. And because of possible infection, abnormal structure of the kidneys because of those cysts, and because of the stasis of the urine, those stones can develop faster compared to those persons that did not have the polycystic kidney disease. And take note that the person will also end up with high blood pressure. For what reason? Well, remember the pathophysiology. It said there that because the cyst will actually fool the kidney that it's not supplying enough blood, it will trigger the activation of the RAS mechanism, right? And so again, it will trigger the vasoconstriction and also the reabsorption of sodium and water, leading to the hypertension. And it's not like a hypertension that's around 135 over 80. That's kind of mild. But this is actually somewhat bothersome kind of high blood pressure here. We're talking about 160s, 150s, 170s, or even in the 200s. And this could really lead into the aneurysm rupture. And we also have the palpable abdominal mass. And again, this is probably the first trigger that the doctor would really want to investigate further by ordering ultrasound in the abdomen or maybe CT scan to investigate further. And of course, with that, there will be an enlargement of the abdomen. There will be, there will be a girth enlargement, abdominal girth enlargement, I should say. All right. Now, I hope that you're able to capture those assessment findings, because I really want to cement of what you just heard in the pathophysiology. I want you to cement that concept with the assessment findings. So I hope that you're retaining some of these concepts slowly, or little by little. Now, we'll talk about the different diagnostic tests of the APKD. And again, The autosomal dominant polycystic kidney disease is usually diagnosed using family history, which is very important. The ultrasound guided CT scans, and also the clinical signs like high blood pressure or the kidney failure. All right, we're not talking about ESRD yet. Now, first and foremost, we are going to tackle the renal ultrasound or the kidney ultrasound. This is the first line and the preferred diagnostic testing to find out ADPKD. And this is because it is non-invasive, it's widely available, it's cost-effective to visualize the kidneys. And the ultrasound of the kidney can also easily detect the presence of the multiple cysts, which is really the hallmark of the ADPKD. And again, remember that the ADPKD involves the large fluid-filled cyst, and these are easily visible on the ultrasound. And again, that's why it is a reliable diagnostic tool. However, though, if the cysts are not huge enough yet, maybe the cysts are still developing and probably not so easily detected by the ultrasound, then we have the abdominal CT scan, which is great for detecting smaller cysts, all right? And those cysts that are not easily visible on the ultrasound. And why is this so effective? Well, the CT scan can pick up very small cysts, and it can also give us better pictures, much more in detail, especially during the early stage. And also expect here that the genetic testing is another tool in order for the medical provider to really identify regarding the development of the ADPKD. And so this testing will really confirm this diagnosis, especially if in case the imaging results are pretty unclear, or let's say when there is a family history of the disease, but no clear clinical symptoms. Now, the genetic testing will involve the analysis of a sample of the DNA, and this is going to be collected via blood sample, and to look for the mutations in the PKD1 and the PKD2 genes, which I said in the first two slides. And again, these are the two genes that are mutated, responsible for the development of the ADPKD. Now, for the genetic testing, this is going to use the direct DNA sequencing, which can definitely identify the mutations in both PKD1 and 2. And this is much more helpful, especially for those young patients or younger patients who might not yet show any significant cyst development, but maybe they only have some history of the ADPKD. So just those three. I don't have any more. Now let's move on into the nursing interventions here. What can you do for this patient with the PKD? So your nursing actions here will vary greatly. So for example, if your patient is probably manifesting those non-life-threatening manifestations, let's say proteinuria, microscopic hematuria, or maybe flank pain, stone formation, they're considered quite in the earlier stage. There's already growth of the cyst, but again, they're considered kind of in the mild to moderate, but they are at a higher risk really to have that kidney cyst to burst, all right? There is a potential, especially if it's not monitored frequently. Now, we're going to talk about the different management here, and please don't be scared with the columns and the rows here because there's a lot of things that we can do. So the first intervention that we have, of course, is to monitor for the hematuria, okay? I'm talking about just everything here. It could be hematuria that is visible or hematuria that is only seen microscopically, all right? So please do that in order that you will anticipate what can possibly happen. Maybe if there is a tinge of blood and maybe the patient has complaints of flank pain and some detection of the kidney stones, I guess this would really give you some relief that maybe it's not going to rupture yet in my shift. always the nurses will think about not having to take care of a dying patient or a very critical patient. That's our wish most of the time. So what can we do here? We're going to have to look for the urinary output, look visually into the urine output, even if the patient probably has a urinary catheter to drainage bag, or let's say when you're emptying the bedpan or the urinal, always do that. And just kind of weird because I've been used to looking into my patient's urinary output. I always do. I I always provide them with the cleanest urinal and empty it right away and clean them out before they'll have to reuse it, because I really want to see those subtle changes, let's say cloudiness of the urine, which could be a proteinuria, or let's say presence of blood. And so I want you to have that careful assessment to remain in you. All right. Now, we're going to end up with limiting the sodium intake for this patient. Why? Well, we know about the RAS mechanism, right? That has been aggravated. There is hypernatremia, elevated sodium level. And so the expected restriction here in their sodium intake will be less than 2 grams per day, because again, they are known to have hypernatremia plus hypertension. We don't want to cause some more elevations in both the sodium and their blood pressure, right? And so we really have to teach the family, for those visitors probably, because they would probably bring food items like Carl's Jr. or McDonald's or whatever salty foods or junk foods that we can find in those drive-through restaurants. And also those drinks that are high in sodium. So you got to teach the family members that we are restricting the patient's intake of sodium. That's part of our care. All right. Now, after that, we're going to have to deal with adequate hydration. So at this point, we're not going to limit the intake of the fluids unless there is a pre-existing contraindications. That is the caveat here. Okay. But generally, if there are no contraindications, what we will be doing, or what will be possibly be ordered by the medical provider, is to increase the intake of water up to 3 liters in 24 hours, if not contraindicated. And I want you to pay attention here. The reason why we want to increase the fluid intake into this patient is to actually suppress the vasopressin. Now, do you remember what is the vasopressin? That is the same hormone, antidiuretic hormone. Okay, so again, that hormone, vasopressin, or ADH, let me write that down. The ADH, or antidiuretic hormone, this is a hormone that is produced by the hypothalamus, but this is going to be stored in the posterior pituitary gland. And once there is a need for the body to release the pituitary gland, this will be triggered by the hypothalamus. It will signal the posterior pituitary gland, hey, I want you to release the vasopressin into the system because we need to conserve water. We are losing way too much water. And that is going to happen in a normal physiology, right? But here, when we are talking about the involvement of the antidiuretic hormone and the vasopressin, that's pretty much the same, right? So what we are wanting to do here, why are we increasing the fluid? Well, we want to decrease the stimulation of the hypothalamus to release the antidiuretic hormone from the posterior pituitary gland. Why? Why do we want to prevent the release of the vasopressin? Well, when this happens, if there is an increase in the release of the vasopressin or the ADH, this can also cause the elevation of the CAMP, which is basically the adenocyclate or the cyclic adenosine monophosphate, which is going to be elevated and can also cause the formation of the cyst and also multiplication of those cysts. So let me write that down. That's CAMP. I hope that you're still following with me. So that is, again, the cyclic adenosine monophosphate. So this is going to be increased if there is elevated ADH. So again, if there is increased ADH, it will also elevate the CAMP. So if we are giving the patient the hydration that can suppress the production or release of the antidiuretic hormone, it can also decrease the release or the release of the CAMP or the synthesis of the CAMP. So both will be decreased. So what is the significance here? If we are going to decrease the stimulation of the hypothalamus to send out the vasopressin, again, it will now slow down the disease process. There will be decrease in the cyst formation. Okay, I hope that you're able to follow me, because that is the rationale why we are promoting 3 liters of fluid intake in this patient. Again, the 3 liters intake is subject to whatever, maybe the patient may have some contraindication. Well, that is up to the medical provider to not order increasing fluid intake. But if there are no restrictions, there are no contraindications, this is what is expected. Please pay attention, okay? 3 liters. And the reason, again, we don't want the vasopressin to be released in large quantities, which can also decrease the CAMP, which can decrease the cyst formation. So basically, we're kind of like slowing down the growth and the multiplication of this cyst in the kidneys or the other body organs, right? So that is kind of like fascinating rationale why the vasopressin is being involved in this disease process. All right, let me get rid of this. Let me erase that. Now, with the, okay, so we are hydrating the patient. We don't forget that. Proceeding with the bed rest. Why? We're only going to allow this to have a complete bed rest for the patient to do that during a possible cyst rupture. Well, no fun. I don't want to be the nurse taking care of this patient. No, just kidding. This is going to be a critical time, because when your patient has bleeding in the kidney, this is really going to cause massive bleeding because of the vascularity of the kidneys. It's a huge bleeder, guys. So your patient's going to end up with hypotension, massive blood loss. There will be rapid changes in their hemodynamics. So what you're going to do here is to make sure that they're on the bed rest at this point, while we are going to plan on doing something else in order to possibly send this patient to the OR. Yes, this is the busiest time when you're going to encounter this problem. And maybe if you're not quite aware, maybe the patient is already bleeding and developing some retroperitoneal hematoma, and you were not paying attention to the skin assessment. Well, that's already there. It's ready to blow up. And so again, keep the patient in bed at this point. Now, to manage the pain, what are we going to do here? Well, there's a whole lot of interventions that we can give to the patient. And one of those is to administer the patient-friendly medication, because we are not talking about liver failure at this time or liver impairment. So acetaminophen would be safe for this patient to manage their pain. And of course, if their pain is so severe, we can always call the doctor or notify the doctor, "Doctor, your patient is not responding to the acetaminophen. Would you mind giving me an order to at least maybe an opiate kind, because our patient's pain level is through the roof, 100/10 per patient's verbal report." And so, yeah, it can vary from a mild analgesic to maybe an opiate or an opioid. All right. Also, another intervention here is the application of the dry heat. And of course, we're not going to do that when there is bleeding. No, We're not going to apply dry heat when there is active bleeding, because the more it can cause vasodilation only when the patient does not have a rupture, right? Please be careful. Now, we're also going to avoid the administration of all the non-steroidal anti-inflammatory drugs. Your Advil, the naproxen, baby aspirin, acetylsalicylic acid. These medications fall into the NSAIDs classification. And why we don't want to give this kind of medication to this patient? Well, this can also become a nephrotoxic substance to the kidney, all right? So it will cause some more insult to the injury. And also, the NSAIDs can also aggravate the hypertension of the patient, because as we know, the prostaglandins can play a role in regulating the blood pressure. And so if we are medicating them with the NSAIDs, this can further increase their blood pressure by causing the sodium and also water to retain in the renal tubules. And this can go back into the circulation. And yeah, adding more blood volume and vasoconstriction, we don't want this. And that's why I highlighted that in red. Avoid NSAIDs. Now, another reason why the NSAIDs is supposed to be eliminated in the treatment, because again, this can also accelerate the damage, and also the it can also increase the cardiovascular events in this patient. And it has that, especially for the antiplatelet, right? Like the aspirin, baby aspirin, acetylsalicylic acid. It has antiplatelet property. It's an antiplatelet anti-aggregant. And so when this happens, the risk of bleeding can happen to our patient, and we don't want this into our patient with a possible rupture. No, we don't want this. All right, moving on to the next intervention is prevention of constipation. What are we doing to prevent this? Well, what we can do here is to include high fiber diet in order that they're not gonna end up with constipation, because when the patient gets constipated, they're gonna bear down during the bowel movement. And when there is bearing down, excessive pressure in the abdomen can build up, and it can also cause exacerbation of the pain associated with a kidney cyst. So no joke, right? And so the straining itself, let me put a line here, can cause the cyst to rupture because of the increasing intra-abdominal pressure. Cyst rupture, we don't want that, especially with the Valsalva maneuver. And again, diet will be high in fiber. We're gonna have to administer prescribed stool softener or laxatives in order to prevent this constipation. Now we're gonna prepare the patient to this kind of procedure we call as the percutaneous cyst puncture. Okay, so this is a special procedure that will alleviate the consolidation, or let's say the increasing pressure inside the kidneys itself. So we are going to have to drain some of the cysts, and also if there is presence of pus or infection collecting in the renal parenchyma, we definitely need to drain that in order to properly treat the infection, because if we're only treating it with the IV antibiotics, and if there is really a pus collection inside the kidney, it's not going to do anything good. It's just going to lengthen the agony here. There will be abscess into the kidney. So we want to make sure that this is going to be drained, or for example, if it's not going to be an abscess, then we're going to prepare the patient for the percutaneous cyst puncture. And so this is an invasive procedure that would require you to do your diligent nursing actions, making sure that you assess the patient thoroughly, make sure that you had secured the consent after the physician has finished talking to the patient regarding the risks and the benefits. Also what do you call this? Yeah, those kind of things. The indication of the procedure and the risk and the benefits and what to expect after the surgery. So those are the things that need to be discussed by the medical provider to the patient and making sure that their questions have been answered as well. Now, part of the care here is to prepare the patient on nothing by mouth at least 8 hours before the procedure. And also, we're going to have to assess thoroughly the patient's medical history regarding their allergies, also the medication history. We don't want to miss out on those information because possibly they have some medications that are really critical that needs to be continued and may need to be ordered by the physician during the hospitalization. We want to make sure that this is thoroughly reviewed by the doctor as well. And also focus into the coagulation studies. Please take note. And because the kidneys is a huge bleeder, right? And the coagulation studies, which include the PTT, APTT, INR, bleeding time, clotting time, those are important lab studies so we can identify if the patient probably has some kind of elevation of these values that can probably cause the patient to bleed out during the procedure. So we want to make sure that the patient's problem is identified this time so we can address this. So maybe there's a need for us to add some medications or prescription in order to decrease the elevated APTT or the PTT. Or maybe there is some kind of a bleeding disorder, maybe a deficiency in the clotting factor that needs to be addressed as well. Okay, so maybe that will call for a preparation for, let's say, cross-matching of the blood, for possible blood transfusion, or possibly the administration of fresh frozen plasma because of the clotting factors that are present in the fresh frozen plasma before the surgical procedure is going to be done. All right, so I hope that you're writing them down there. So let me just put here possible blood transfusion. I'll just put BT, stands for blood transfusion, or the administration of FFP, which is the administration of those clotting factors in the fresh frozen plasma, and also checking those PTT, partial thromboplastin time, or the prothrombin time, INR, clotting, and bleeding time. All right, bleeding time. I'll just put here BT. All right. So those are the things that you need to investigate, especially that this procedure is such a bleeder. Okay. All right. Now we're going to have to turn the page here. We're going to talk about the other nursing interventions, which will also include the control of the blood pressure, which is, of course, the hypertension, right? The patient is hypertensive right now. So what is expected here? Well, part of the care is the assessment of the blood pressure, regular monitoring of the patient's blood pressure. Yeah, lucky you, right? If your patient's blood pressure probably hangs around 140 over 80, or let's say 150 over 60, or something like 150 over 90 or 85. And so maybe you're going to do the routine blood pressure or vital signs monitoring every 4 hours. But if your patient has a blood pressure of greater than 160 or 180 in the systolic, or maybe 100 or maybe 200s in the systolic, or let's say we're talking about a blood diastolic pressure of greater than 100, maybe 120, 110 diastolic, you're going to keep an eye on that one. You have to really control the blood pressure until it gets much more stable, at least to a safer range, even though it's still high, but much to like a mid-level that will not cause rupture of the kidney. And so one of the medications that we're going to expect here is the angiotensin converting enzyme inhibitors. So again, this can cause some vasodilation. It will really control the blood pressure, and it can also prevent the retention of the water and sodium in the kidney tubules, right? And so that is why it is effective. And then we also have the beta blockers, could be in the form of the metoprolol or loprazole, or the calcium channel blockers, Norvasc, or if the patient probably has or not able to take anything by mouth, then think about the verapamil, probably. Or the thiazides, which is a diuretic that can also be powerful in excreting those extra fluids, right? And also the sodium. And we have the loop diuretics, which is also going to be part of the treatment. It doesn't mean that you have to administer all of these. No. Not all these medications will need to be ordered. But there will be some kind of routine medications that can be ordered like daily, probably, but not all of these medications will be given. So again, there'll probably be a variation of a routine medication or maybe a PRN antihypertensive medication, maybe some form of labetalol, which is both adrenergic, alpha or beta blocker, or it could be a use of Lopressor IV. So it depends on the physician. Now we're also going to slow the progression of the autosomal dominant polycystic kidney disease. By how? We are going to do that with this new modality we call as the administration of tolvaptan. So this is a medication that can actually slow down the progression of the ADPKD. Okay, so what is its effect? It will block the effect of, ADH, antidiuretic hormone, or known as the vasopressin. Remember about the effect of the vasopressin, that it can also increase the synthesis of your CAMP. And when that happens, it can hasten or will allow the formation of new cysts and growth of those cysts. So we want to administer this because of that effect, to block the vasopressin or the antidiuretic hormone. All right. The same action regarding, it's not really the same action, quite similar though. The ones that we did in the previous slide about giving them at least 3 liters of water per day in order to prevent the secretion of the antidiuretic hormone by the posterior pituitary gland. So it has that same kind of mechanism. The only thing about the tolvaptan though, it's because it's a little bit pricey. Okay, and this is the only medicine that is approved by the FDA for the ADPKD high-risk cases. Okay, and it also has some known side effects, and so this is only recommended for those patients at higher risk for the disease progression, let's say end-stage renal disease. So this is only reserved for those patients, okay, in order to really halt the progression into the ESRD. And so if the patient's manifestations are quite controlled with the other modalities, let's say not involving the use of tolvaptan, then probably those are kind of like, we call as enough. But this is something that is kind of somewhat like reserved for those patients that have the higher risk to really develop into the end-stage renal disease. Again, it is very pricey, and it's the only medication that is approved by the FDA to the recent time, okay? Now, we're going to talk about the next intervention here, which is to prevent or treat urinary tract infections. Remember, in the pathophysiology, because of the presence of the cysts, this can cause the stagnation of the urine, and it can lead into the bacterial growth. It will become a medium for the bacteria to grow. And also remember about the recurrent urinary tract infection, which is the staghorn type, the struvite kind of stones. So if there is that kind of UTI, well, of course, that can lead into the development of that staghorn type of stone. So how are we going to treat or prevent the occurrence of UTI? Well, patient education is very important here. You got to teach them about how to properly do the hand hygiene. and make sure that they're practicing perineal care. Yes, very important. And of course, antibiotic therapy here would be one of the nursing actions. And this is going to be scheduled, intermittent IV infusions. We want to make sure that we're also evaluating the patient's response to the antibiotic therapy, if they're responding to it. And also, if this is an antibiotic that possibly would cause some complication to the kidney function, this is something that we need to look at. Maybe you need to go into the creatinine levels to see if there is a change in the values, the creatinine clearance and also the serum creatinine. Now, we're going to have to prepare the patient for hemodialysis, or let's say kidney transplantation, if the patient is in close to developing end-stage renal disease. And this is going to include your preparation, health education about their need to have a temporary dialysis port or access device, because the formation of the AV fistula will require about 6 to 8 weeks to mature, all right? So after the surgical procedure, let's say, for example, the cardiovascular surgeon has created this kind of fistula, which is there is going to be anastomosis of the venous and the arterial blood vessels. This cannot be used immediately. No, it has to be matured first for about 6 to 8 weeks. And there's a whole lot of nursing care that's going to be involved with that, especially checking for the thrill and the bruit when it's, even if it's still not mature, we have to make sure we are checking on the integrity of the fistula. We're not supposed to be checking the blood pressure, no needle sticks, no venipuncture, no IM injections, no application of whatsoever any pressure into the arm, because this can cause clogging, coagulation, or clotting of that fistula. All right. Now, we are going to, again, like I've said, I almost got distracted here. With a temporary dialysis catheter, this is something that can be easily or that can be readily used when the patient will be needing immediate dialysis at that time. Okay, so another set of interventions will be involved here regarding maintenance of the dialysis catheter. We're not supposed to use that for infusing medications. We're not going to administer IV fluids through that dialysis catheter. That is only indicated for the hemodialysis. There's so many rules about or policies about not going to disturb the integrity of the dialysis catheter, because this is only intended for the dialysis only. We're not supposed to draw blood in there unless it's a specific kind of port that can allow you to draw blood from it, because there are different dialysis ports as well. There are some instances that it has some kind of a branch that you can use to draw blood or maybe administer medications, but most of the dialysis access that I've seen so far don't have that port that will allow you to administer medications. So you've got to be careful in assessing what kind of port your patient has. Now, offer genetic counseling and also provide psychological support. Yes, this is something that we can easily neglect, but this is often asked also in the NCLEX. So we know that the emotional impact of the disease really on the person is just too much. And we want to make sure that the patient is offered counseling, psychological support, or maybe with the involvement of a counselor, including the family members especially, because there is a possibility that there probably going to be a need for kidney donation, maybe with the closest kin. And so this is a possibility that will be discussed in this kind of scenario. Now, we are also going to prepare the patient for nephrectomy. When are we going to prepare the patient for nephrectomy? We are going to do that if the patient will have unbearable abdominal discomfort. Let's say there is really a rapid increase in the kidney size that it's really about to burst. There's anorexia, discomfort, renal cell carcinoma, or probably renal hemorrhage. Then this is going to be the time that you really need to prepare the patient for the immediate removal of the kidney, because the patient here will end up with massive blood loss. So an emergent surgical procedure will happen pretty soon. Like, again, you really need to assess your patients if they are really into this point that they're going to bleed out or rupture. Now, our nursing care here will be too many. I did not put everything in here. So all those nursing interventions that are going to be involved in the pre-op and also the post-op will be included here. But I can mention some of the post-op care, which is basically going to check your patient's stability with the vital signs, open airway, making sure that you're checking the dressing, if there's any kind of wound vac drainage, maybe an appliance. You have to take note on the amount of bleeding to see if it's an acceptable range of drainage within the 24-hour period, or let's say if there is a sudden increment in the volume of the blood flow. That's not going to be a good sign. That simply means that there is an active bleeding going on. So you have to report that to the physician right away. Now, at this point, we're going to talk about hydronephrosis. So this is going to be a totally different topic, but would be much easier, less dramatic compared to the ADPKD. All right, so the hydronephrosis is a problem that can result from a hindrance, or let's say an obstruction of the urine flow, which can cause a buildup of urine inside the kidney. And so this is easy. You're gonna really recognize right away what are the possible causes. Well, yeah, let's take a look at this picture first. Kind of fascinating to look at. So your patient with the hydronephrosis, look at that. There is now an engorgement of the ureter into the right side of the picture. So the right or the left ureter, okay, this is your, I can't see my pointer here. Let me see if I could do that. Okay, I have to decrease the size. Okay, so you have the diseased kidney right here with the hydronephrosis going on into the left kidney. And it's possibly because of a trapped urine right here. And this is caused by possibly a stone that has lodged into one of the narrowest section of the ureter. And so when this happens, there will be collection of the urine into the section, and it can now distend that area up until it goes back up into the parenchyma of the kidney, into the calyces. So it will now cause that edema into the kidney. And remember about the different post-renal factors that I mentioned during the first day of our discussion about the renal failure in the acute kidney injury. This is basically one of those factors, post-renal factor. And so this will now cause damage to the glomeruli and to the nephron if not addressed urgently, okay? Now, another cause here is possibly tumors that is now causing obstruction into the outflow of the urine coming from the ureter. It could be a tumor in the bladder. So if that is huge enough, maybe occluding or maybe it's now creating a huge space into the bladder. So it is now restricting the outflow of the urine coming from the ureter into the bladder, or maybe from the left ureter into the bladder. So that is a possible reason. Or maybe if the patient has prostate enlargement, or what we call as the BPH, the benign prostatic hypertrophy or hyperplasia, wherein there is now going to be a problem way down below here with the neck of the bladder. So let's just put an additional prostate gland over here. So if there is such an enlargement of the prostate gland in the case of the BPH, it will now constrict the bladder neck here. So what's going to happen? There will be a slow outflow of the urine from the bladder into the urethra. So when this happens, again, there will be collection of the urine in the bladder. It can cause backup into the kidneys as well. All right. And I cannot count for how many patients that I had dealt with, especially with the male elderly population. It's sad that they have to endure this kind of problem on their old age. And it's really disheartening to just see them suffer especially at nighttime, that they can't sleep because they feel like they need to go to the bathroom and they just can't empty their bladder. And of course, we have treatments for that, right? Like the um, what do you call this? Tamsulosin, which is actually one of those medications to help relax the neck of the bladder right here. And so we're going to talk about that the next session tomorrow. And so again, the essence really here is to identify the different causes of the obstruction, which will eventually cause the hydronephrosis, really. That is the edema of the ureters and the kidney caused by the obstruction. So it's very simple. Now, what are the assessment findings here? Well, there's going to be high blood pressure, of course, and there is also some headaches, and there will be some intermittent or persistent flank pain that will spread to the groin area. All right, so take note of these three pressing assessment findings: blood pressure that is high, headaches, and also intermittent persistent flank pain that is going to spread to the groin area. Well, why? Well, these symptoms will appear because of the increasing pressure within the kidney due to the urine buildup. That is the only rationale why the patient has the high blood pressure, headaches, and intermittent persistent flank pain radiating to the groin. Again, that's because of the increasing pressure within the kidney due to the urine buildup. I was actually expecting some more explanation, but can't find anywhere else. Now, let's talk about the nursing actions. Why are we going to do this? There's a whole lot of stuff that we can do. We're going to monitor the vital signs to capture if there's any elevation of the temperature. Elevation of temperature is no fun, especially if the patient is now developing urinary tract infection, because there is stasis. There is backflowing of the urine coming from the bladder to the kidneys. And remember, guys, that the kidneys are highly vascular. When there is an ascending infection coming from the bladder to the kidneys, the infection, especially the microorganism, can readily cross into the systemic vascular compartment. This is now what we call as septicemia, bacteremia, which is no joke. Another risk that you need to attend to. Whenever the patient will end up probably with BPH, and mostly in the elderly population, one of the signs that they are having a renal or a urinary tract infection is confusion, disorientation. So for those elderly people that are quite there yet, they're not confused, they're alert oriented times 3. And so if there is a sudden change in their cognitive function, their level of mentation from being alert into getting sleepy, lethargic during the day, because their prior history is that they're always active during their daytime activities at the nursing home, or maybe in the assisted living, or maybe at home they're quite active. And all of a sudden, the patient is kind of groggy, sleepy, not eating. They just want to be in the bedroom most of the day. That's a red flag, guys, because possibly the patient is developing urinary tract infections. And it's no fun, especially if you're in the med-surg setting and the patient comes from the nursing home or the assisted living, and there they don't probably get to drink adequate amounts of water and probably poor hygienic practices. They're gonna get the urinary tract infection so easily that by the time they get into the unit, they're gonna be so confused, very combative. They're gonna remove their IVs, they're gonna rip them off, they're gonna climb out of bed, they're not gonna sleep even at 4 a.m. during the nighttime. I work in the night shift for 15 years, and I have enjoyed all those fun experiences. And so it is quite fascinating to really take care of these people, because by the time that you admit them, they're quite confused. But during the second or third day, when the antibiotics finally kicked in, they're going to go back into their mentation that is alert oriented. It's quite amazing that they're behaving so nicely during the third shift, right? And so you will just talk to your nursemates that, hey, that was my patient the other night that was very combative running down the hall. So that is going to be a common thing that can happen in the med-surg setting. It's no fun. Now, we're going to talk about checking the fluids and electrolytes imbalances. This is going to be another assessment finding or a nursing action that you should be doing, because your patient probably has probably a hidden imbalance. Maybe they have some form of hyponatremia. Maybe they are taking some medications for their blood pressures, let's say thiazide, okay, which is a diuretic. And some of these medications, let's say the thiazide diuretic is one of the main antihypertensive medications, first line antihypertensive medications, and it can target the sodium level. And so when they take the thiazide diuretic, it can cause the sodium level to go down. And this is something that is not going to happen rapidly, because most of these patients are going to take these medications for a long time. And so this will progress slowly. And most of the time, the symptoms will kind of be not easy to capture because it's kind of like similar to like, the nurses are probably used to the disorientation of this patient, so they're not really capturing those subtle changes. But for me, most of the manifestations that I have dealt with, especially with the thiazide diuretic, their sodium level goes below than 130. Let me rewrite that. Less than 130 milliequivalents per liter. That's already considered as hyponatremia. Some of my patients are actually in the 120s already, or even the lowest that I had a chance of taking care of was, I think, 112 or 114. Yeah, this is worst. The patients here is going to be obtunded, almost close to comatose, and they're prone to developing seizures. Quite fun. Another priority problem. So let's not get distracted way too much with that. I'm just giving you a heads up of what possible fluid imbalances that can occur into our patient using medications. Now, another thing that we need to know is to monitor for excessive urinary output. Well, with that, if there is probably use of diuretics, they can really get dehydrated. And so you need to really have a thorough assessment of your patient. Look into the laboratory reports of the patient. What medical history do they have? What medications are they currently taking? And what possible complications that could have brought this polyuria? Now, you also need to check for the daily weight of the patient and make sure that you're going to report significant increase or significant decrease of the patient's weight. And you have to have a consistent time of weighing your patient. So if it's been done daily, most of the time it's done before breakfast, after the patient uses the bathroom, making sure that they're wearing the same type of clothing, in order that you can really get the dry weight of this patient. Now, another assessment is to look into the laboratory of your patient, such as the urine specific gravity. Okay, that is very important because it will help us tell the concentration of the urine. If the urine is somewhere close to maybe 1.030, anything like, let's say, close to 1.025, that is already considered as concentrated, right? And anything below 1.010, that is considered as diluted urine. Again, the specific gravity is your basis to tell you if the patient is concentrated or way too concentrated in their urine output, or if it's too diluted. Okay, you got to investigate those kind of variations in their specific gravity. Now, another thing that we need to keep an eye on is about the serum albumin, which is another factor, especially because if there is a decrease in the albumin, remember what I said about the albumin's role, the sponge effect? Remember that it will act as a sponge. And I'm just going to draw here. This is the vascular compartment. And let's say this is the protein. I'll just put CHON, standing for protein, and the water here. Okay? And here are the cells and the interstitial spaces. These right here are the interstitial spaces. And so if there is now low albumin level, like hypoalbuminemia, remember, if there is a lack of the albumin, then it will lose its job as the sponge. So what's going to happen? The water or fluids will now shift into the interstitial spaces. Okay? So we are losing fluids from the vascular compartment, and the water is now congregating into the interstitial spaces. That's why you're going to see those edema. Those are I would consider them really as non-circulating fluid because they are staying in the interstitium. And so this is really going to deplete the body from the circulating fluid volume. And so again, look into the albumin, all right? Because it serves as it will be responsible in maintaining the oncotic pressure. I hope that you still recall this. The oncotic pressure is the amount of pressure that the albumin or proteins exert, okay, in order to keep the fluid to stay in the vascular compartment. Another term of the oncotic pressure is what we call as the colloidal osmotic pressure. Again, this is the kind of pressure that the proteins exert. Colloidal osmotic pressure. Right. I apologize for my handwriting, just using the mouse right now. All right. So that's why I really want you to pay attention regarding checking the albumin. Now let's get rid of that. Also, the glucose levels. Why are we going to look into the glucose levels of our patient, especially with the case of hydronephrosis? Well, it is very important, especially in those patients that has a history of have a diabetes history, because this can also contribute to the kidney dysfunction and also can exacerbate the hydronephrosis related complications. So if there is an elevation of the blood glucose, this indicates that there is poor management of their diabetes, which can also further impair the kidney function and over time will also worsen the hydronephrosis symptoms. Now, moving on here, we're going to have to administer the intravenous fluids as prescribed, and this is going to be dependent as well in your assessment. And careful, guys, as nurses, especially newbies, it's not because you have an order from the doctor that, hey, I'm okay, it's ordered, I'm not going against the doctor's order. Hey, your job as a nurse, you have to pay attention into the hemodynamics of your patient. If your patient is not putting out the same amount of urine, then that's something that would be a red flag. That probably would cause you to be much more concerned. Maybe the patient that you're taking care of has developed some form of pulmonary edema that in just a matter of few hours, your patient's gonna show some shortness of breath because of the exacerbation of the congestive heart failure, third spacing. So you have to be careful even with the intravenous infusion. That's my advice for you guys. Especially with the elderly population, they have so many comorbidities that you probably are not familiar. And so make sure that you are assessing your patient's lung sounds every now and then when you are treating your patients with IV fluids. Now, another thing that you need to do is to make sure that we are going to prepare the patient for nephrostomy tube insertion. So what is this? This is going to involve, this is actually an invasive procedure, which will involve the insertion of a tube into the kidney itself to drain the fluid. Okay, so this is an invasive procedure that will be done with uh, imaging as well. Okay, so before we're going to send the patient to the procedure room, we're going to have to carefully do a thorough assessment, make sure that we are collecting the data here, medical history, medication history, allergies, and also make sure that we are educating the patient about the procedure, what it is supposed to do, and the possible complications, and what should be done after the procedure. That constitute your education, along with the pre and post-op exercises, because possibly your patient will end up maybe with a major surgical procedure if something goes so problematic with the procedure. So you got to be prepared. Make sure that there is a consent that has been signed by the patient, or maybe their medical proxy. If they're not able to do it, they're not on the right mind to decide for themselves. And so make sure that you have that consent signed by their medical proxy or the conservator. Make sure that you're going to prepare the patient for the procedure. Keep them NPO. And establish an IV line, because you're definitely going to need that for the administration of IV fluids and also antibiotics and pre-op medications, and possibly the administration of the pre-op antibiotic or analgesics, because your patient's complaining of the pain. Now, part of the care here is to make sure you are also preparing the patient psychologically, because this is foreign to them. They're not really expecting to have a surgical procedure from having the flank pain or whatever, and so, or the headache or the hypertension. So this is quite a big change for them. It's definitely gonna disrupt their lifestyle. So have some empathy to your patient. Have some empathy. That's my advice. Now, what are we going to do here? It's to intervene after the procedure has been completed. So, for example, the nephrostomy tube has been successful. And so what we're going to do here, we're going to proceed with checking the patient's vital signs regularly and to assess for their pain level and address the pain. And we're going to have to monitor the nephrostomy tube, also looking into the insertion site and watching for any signs of infection. So the nephrostomy is going to look like this. So let's zoom in here. So the tube is actually going to be inserted right here percutaneously, and this is done in surgical manner. So the tube will be advanced into the kidney, and this is going to drain the urine. All right. And so this is going to be connected into a tube. Okay. And of course, post-op, you will see a dressing right at the entry, at the insertion site. So this is going to be covered by occlusive dressing. It's like a pre-cut dressing, self-sealing dressing. And this is going to be connected to a tube that has like a, what do you call this? Like a stopcock that you can open or close. And this is something that I really don't like about it, because some patients would play on the stopcock. And especially if they're confused, they're going to play around the stopcock, they're going to close. And by the time you come back, maybe an hour later on, it's clogged. How fun is that? And so that's the part that I don't like about taking care of the confused patients, especially with these special procedure and no one is watching them at the bedside, because they can do a whole lot of weird things. Even pull out the nephrostomy tube. No fun. And I don't want to discuss further about placement of restraints, because I've gone to that point already, that I have to apply restraints to my patient because they are way too confused to deal with these contraptions. And so, like I've said, the tubing will be connected to this closed system device, and it will be drained into a smaller bag like this. But what's fun here is that mostly in the surgical or post-procedure, our patient will be putting out a lot of urine. And this small bag can only accommodate about half a liter, like 300, 400 mLs. And what you're going to expect here is that they're going to be putting out a lot of urine, especially if they're connected to the IV fluid infusion. So expect that you're going to be in the room, or maybe the nurse aide will be asked to help you empty the bag frequently, because this can fill up so fast. And so one of the skills that I have learned is to actually connect this port right here with the Foley bag catheter, or the Foley container, which can accommodate at least like 4 liters. And so that's what I did. And so I don't have to go back to the room every 15 or 30 minutes just to empty this bag. Okay. So what you're seeing in the picture right now is basically just a standard nephrostomy bag, but mostly in the acute phase. What we're going to expect to see here is that it will be connected to a much bigger bag in order to accommodate much greater volume of urine. But the same principle applies. Make sure that the bag is lower than the site of insertion. Make sure that it is allowed to drain properly and not sluggish, because if there is kinking or maybe possible closure of the valve here or the stopcock, it can really cause the sluggishness. It can potentially get blocked by those sediments probably, or maybe some casts that are found in the urine, and so we don't want that happening. All right, so that's pretty much it about the picture. Let me reduce that so we can proceed with the discussion, because there's a whole lot of stuff that we still need to go through. Oops, let me go back here. Moving on to the next portion. We are going to have to promote or provide wound care to this patient during the acute phase. And this is the best time for us to involve the patient, especially when we are doing the wound care dressing, or maybe a helpful family member or the caregiver. This is the best time that we can assist them or show to them how to take care of the nephrostomy and also caring of the dressing. All right. Now we're also going to administer antibiotics here, because of course the hydronephrosis will usually accompany with the urinary tract infections, the administration of analgesics, because of course it's a surgical procedure. It can be painful. And also an accompanying urinary tract infection can also be painful, and also the administration of IV fluids that is going to be expected. Now, as far as the patient education, what are we going to teach to the patient? Well, it's going to be, again, care of the tube dressing change. That's part of it. We're going to have to show them what exactly will be done, what kind of dressings that will be sent to them for the discharge, the proper hygiene before performing the dressing change, and also the drainage monitoring. Make sure that they are aware what is the expected color of the urine, let's say 3 days or 4 days or 5 days after the nephrostomy insertion. So at this point, there will be clearing of the output here. So if there is such kind of an infection that has been going on for quite some time, so what you'll expect here, there will be some clarity of the urine. It's no longer cloudy, right? And there is no bloody tinge in the nephrostomy bag, all right? So please take note of that. Another is to teach them about troubleshooting common issues. So what are these issues? There's a whole lot. So let's start with checking the drainage, possibly maintaining the hygiene. That's one, because again, with the incision where the tube is inserted, this can immediately get infected. If the person doing the dressing change, or let's say if the dressing gets wet, then it can allow those microorganisms to grow and enter the tube. And make sure that we're also going to teach to them skincare surrounding the site, making sure that we are teaching them to make sure that the site is dry and intact, and also to properly change the dressing, and also checking the drainage to see if there's any kind of wetness around the dressing site or the surrounding skin, and also the positioning. And one of the things that I really don't like about this, um, what do you call this, nephrostomy tube, is that when the patient sleeps, they can potentially sleep on the side where the nephrostomy tube is inserted. And this is the common thing that we encounter as nurses, that we keep reminding them to not to sleep on the nephrostomy site in order to prevent the kinking or possible detachment of the tube. Okay, so even if we secure it properly, applying tape and stuff, anything could just happen, which is going to surprise you. Yeah. And another thing is to make sure you're securing, you're teaching the patient or the caregiver to secure the tube, the line, and also managing their discomfort. So if they have routine PRN medications maybe to take during their discharge, then teach them as well when to take their PRN pain medications, and also to recognize for possible signs and symptoms of complications. That is also important, and make sure that you are going to teach them if in case that there is dislodgement or detachment of the nephrostomy tube. And this is the nightmare that you don't want to happen in your shift. And so if there is such accidental removal, then you're going to teach the caregiver or the patient to apply pressure directly into the insertion site, and they need to contact the medical provider right away and seek emergent medical care, and tell them not to attempt reinserting the tube because it's already contaminated. Reinserting the tube can introduce more microorganisms into the kidneys, and cover the site with a clean towel if they don't have anything available at home. Maybe they ran out of the supplies. A clean towel would do, and make sure that if there is maybe if they have available dressing with them, then let them do that. Cover the dressing. So again, these are the scenarios that could be possibly asked in the NCLEX. This is the reduction of risk potentials. Yes, not kidding. And so we're going to answer some questions here. Actually, I only prepared 2 questions, but they're both select all that apply. So we have the first scenario here. It states, a 45-year-old male patient is admitted with a diagnosis of autosomal dominant polycystic kidney disease, or the ADPKD. And his laboratory results reveal the following: serum creatinine of 2.1 milligrams per DL, blood urea nitrogen of 45 milligrams per deciliter, estimated glomerular filtration rate of 92 mL per minute, urine specific gravity of 1.005, and urinary protein of 2+. And what else? Did I add some more? Serum sodium of 147 milliequivalents per liter, and there is also pyuria, presence of pus. So which of the following clinical features are associated with the autosomal dominant polycystic kidney disease? Select all that apply. All right. Again, let me read that back. A 45-year-old male patient is admitted with a diagnosis of autosomal dominant polycystic kidney disease. His laboratory results reveal the following: serum creatinine of 2.1 milligrams per DL, blood urea nitrogen of 45 milligrams per DL, estimated glomerular filtration rate 92 mL per minute, urine specific gravity of 1.005, urinary protein of 2+, and we have a sodium level of 147 milliequivalents per liter and pyuria. Which of the following clinical features are associated with autosomal dominant polycystic kidney disease? Select all that apply. Your options are hematuria, hypertension, there's also hypotension, flank pain, palpable abdominal mass, polyuria, glycosuria, hypernatremia, proteinuria, hyperkalemia. Again, the options are hematuria, hypertension, hypotension, flank pain, palpable abdominal mass, polyuria, glycosuria, hypernatremia, proteinuria, and lastly, hyperkalemia. I'm going to give you time, so select your answers right now. All right, time is up. You can always go back to the scenario after this live stream. And so let's go through the scenario here. I really want you to use your critical thinking here. Even just starting with a scenario, you're really going to capture so many findings that can help you point out the answers or can help you point out those erroneous options. So our case here is talking about that ADPKD, right? 45-year-old male, all right? And the reason why the patient was admitted is because of the UTI, right? They're not going to come into the hospital because of a headache. No, I don't want to. I don't like the hospital. I've never been to a hospital myself. I've never been. Maybe outpatient clinic, but I don't want to be hospitalized myself. I don't want to. I don't like the stress in the hospital. So the laboratory results here reveal the following. Serum creatinine of 2.1. What is that? Is that normal? I want you to think. Is that within the range, or is it low? Is it high? Blood urea nitrogen of 45. Is it high? Is it low? Is it within the range? Is the glomerular filtration rate of 92 mL per minute within the range? Is it high? Is it low? Is the specific gravity 1.005 normal? Is it low? Is it high? Is the protein 2 plus normal? Is the serum sodium 147? Is it normal? Is it high? Is it low? In the presence of pyuria, presence of pus in the urine. So let's take a look on the first option. What is hematuria here? Is it going to be one of the expected clinical features in the ADPKD? Let's review. Remember about the pathophysiology I mentioned, that the hematuria, especially those microscopic type of hematuria, this can occur in the ADPKD because of the possible urinary tract infections, or it could be the problems with the tubules itself or the glomerulus itself. So it can now possibly cause the leaking of the red blood cells into the urine. And so this is one of our answers, hematuria. Okay, I did not put anything in the scenario about bleeding or rupture. No, I did not say anything about it. I did not put anything any information about struvite stones, or let's say calcium oxalate stones, erosion of the what do you call this, the ureter. No, we don't have that information. So you're going to focus into what is only available in the scenario. Okay, now hypertension. What do you think about the hypertension? Is this going to be one of those clinical features? But again, I want you to go back into the pathophysiology. What is happening into this patient with the ADPKD? And remember, guys, that with the enlarging size of the kidney, this can cause compression of the blood vessels, right? Which is really going to fool the kidney to detect that, hey, I'm not getting enough blood oxygen, or yes, I'm not getting enough perfusion, or let's say I'm not getting enough blood to supply the tissues in my kidney. And so with that, it can trigger the what? The RAAS, or the RAS mechanism. And remember about the RAS mechanism, it can lead to hypertension and also the retention of sodium and water. So those are the two effects of the RAS mechanism because of the angiotensin 2. Okay, so we are going to select this as one of the answers. Well, we got number 3, or select option hypotension. Immediately get rid of that because we never talk about hypotension in the pathophysiology, right? Remove that. What about the flank pain? Did we talk about the flank pain in the pathophysiology? Yes, we did. And so that is going to be one of the answers. And the reason for that is because of the enlarging kidneys, because of the enlarging cyst, it can cause pressure into the renal capsule. That can lead to the flank pain. And another reason for that is because of the possibility. I'm just gonna talk, not gonna talk about it. We'll just limit to the flank pain. Okay. All right. Now, we have the 5th option, palpable abdominal mass. Yes, of course. The palpable abdominal mass is one of the features that you should not miss. This is going to be present in the ADPKD because of the enlargement of the kidneys from the numerous cyst. Pick that one. What about polyuria? Did I mention about the polyuria earlier? Yes, right? Okay, the polyuria, while it doesn't always gonna happen, it's not 100% present in all the cases, but it will be there. So this is a common finding in the ADPKD, but it can also occur in other renal conditions. We are selecting that. What about glycosuria? Presence of glucose in the urine. Well, we never talked about this earlier, right? And this is something that is only associated with diabetes mellitus, an overflow of the sugar into the urine because it has already reached its renal threshold, which is actually 160 milligrams per dl. Remember, guys, milligrams per dl. This is the renal threshold for glucose, 160 milligrams per dl. What I'm trying to say here is that when your blood sugar goes higher than the 160, let's say you are eating way too much sweets, cake, sugary drinks, of course your blood sugar will spike, right? After you ate that high sugary food, donuts, whatever, confectionaries, coffee with a lot of sugar in it, your blood level will reach 100, greater than 160. That would be good if you have a well-functioning pancreas, right? That you can, what do you call this? You can manage it by causing the insulin to be released to cause this blood sugars to go into the tissues. But for those patients that are diabetic, they are not able to really do that. And so the sugar will now spill over the urine when they reach this threshold. And so it will be detected in the urine specimen. There will be increased blood sugar in the urine. And so this is something that is not associated with the ADPKD. So we are going to eliminate that. Okay, we did not talk about glycosuria at all. Now think about the hypernatremia, which is our next option. The hypernatremia is what? Is it present in the ADPKD? Yes, we did. And again, the reason for that is the RAS activation. Remember, the angiotensin 2 activation can cause the renal tubules to reabsorb the sodium ions and also the water. That is why there is hypernatremia. Remember, I highlighted that in the, let's go back into that right here. Remember, there's that, where's the hypernatremia? Did I put it there? Probably not, but it's somewhat engaged right here in the RAS activation. Okay, now let's go back into our slide. Where are we at? Second. Are we there? No. Whoops. Okay, so hypernatremia as a response to the RAS activation, this is expected to this patient. Now, how about proteinuria? Hypernatremia is one. Proteinuria. Did we see proteinuria in the pathophysiology? Yes. And the reason for that, it's because it's allowing the proteins to leak out into the urine. okay? So most of the disease processes that I have lectured on, nephrotic syndrome, we got the glomerulonephritis. This one, there's proteinuria. So we're gonna include that one. What about hyperkalemia? Is this going to be present in the patient? We did not mention about this one in the pathophysiology. Well, I've researched well into this, if this is common, if hyperkalemia is noticeable. Apparently, no. The hyperkalemia can only be present only if the patient is in the end-stage renal disease, okay? But in this scenario, is the patient in the end-stage renal disease? No. Look into the glomerular filtration rate of 92. Go back into this value within the normal range. So anything above 90 mLs per minute, they're still good. But when your patient has end-stage renal disease, let's say their eGFR or the glomerular filtration rate is somewhere close to about 15 mLs per minute, then that is what we call as end-stage renal disease. And so hyperkalemia is not present in this patient. So we have our correct answers: hematuria, hypertension, flank pain, palpable abdominal mass. We have polyuria, hypernatremia, proteinuria. So only two wrong options are supposed to be here: hyperkalemia and hypotension. So I hope you were able to get the rationale about this test question, but I'm not done yet. I haven't really taught you about the test taking skill. And so at this point, we're gonna focus onto the key indicators. Let me erase that. So to decrease the confusion, we're gonna have to look for those specific lab values that I indicated: the BUN, the creatinine. The BUN is somewhere between 5 or 7 to 20 milligrams per DL. So this is elevated. The creatinine is 2.1. Our normal range is somewhere between 0.7 or 0.5 to 1.2 or 1.3 milligrams per DL. So we are up here, very elevated. And also, what else? The specific gravity that is diluted. There's also protein appearance in the urine. There is hypernatremia of 147. Normally, it's only 135 to 145 in this sodium level. Our patient's value is 147. So that's already considered hypernatremia. There is pyuria, presence of pus in the urine. So there could be abscess in the kidney. And what else? Serum creatinine. Of course, established urinary tract infection diagnosis on top of the ADPKD. What else? Specific gravity, I mentioned already. Yeah, so far, those are the important indicators that you need to keep an eye out. And so what do you want to do at this test item? Well, you have to really pay attention into those key features like the creatinine, the BUN, the urinary protein, also the abdominal mass, right? That is expected already because of the chronicity of the problem. And another tip for you actually is to understand the pathophysiology. Again, you really need to go back into the pathophysiology. If you did not understand the disease process, don't just play along with the mnemonics, because those mnemonics probably would not work for you. So I would rather do something about it by understanding the mechanism that will really stay on in your subconscious for a long time. Not something that would just be like a crash course that will only be present for like a few months, and then after the exam you're going to forget. That's the reason why I don't like mnemonics, because it's short term, okay? And that's why I always recommend understanding the disease process. No one can fight me with this one because it's proven, okay? Now, another thing that you need to do here is to understand the mechanisms. It will really help you identify the correct answers more confidently, okay? Yeah, so I really don't like those false reassurance that you can memorize all the mnemonics. No, That's not 100% foolproof. Now, another thing that you need to do is to consider the common symptoms, especially the clinical manifestations of the ADPKD. Okay, so again, going back into the hematuria, hypertension, the flank pain, the palpable abdominal mass, and also the proteinuria, and make sure that you're going to associate these common manifestations so you can prioritize your options. Now, again, you have to eliminate those incorrect options, the distractors like the hypotension and the glycosuria. Okay, all right. Let's move on to the next question. So basically, we are just using the same scenario, but the question has progressed into a follow-up question. So let me enlarge the screen. Hopefully this will help. So the follow-up question here is, which of the following or which nursing interventions are, let me just leave it like that. Which nursing interventions are appropriate for the management of the patient's condition? Select all that apply. We're only going to ask you about the nursing interventions appropriate for the management of these ADPKD. Okay, so you are going to select all that apply. So option 1 is decrease sodium intake to less than 2 grams per day. Okay, and we have the second option, which is administer non-steroidal anti-inflammatory drugs such as NSAIDs. And then we have option number 3, provide bed rest if cyst rupture and bleeding occurs. And we have the fourth option, prepare for percutaneous cyst puncture or drainage of the abscess. And then we also have offer genetic counseling. And then we have administer tolvaptan as prescribed. And we also have monitor for gross hematuria. And then we have offer psychological support, prepare the patient for nephrectomy, and lastly, encourage increased hydration to 3 liters per day. Okay, I want you to select your choice, so your options right now. Okay, your time is up. So let's go through the different nursing actions. First option said, decrease sodium intake to less than 2 grams per day. I mentioned that one earlier with the management, right? And again, the reason for that is because of the hypernatremia caused by the RAS activation. The kidney tubules will be targeted to reabsorb the sodium ions and also the water. It's because the body is telling them to reabsorb it by the power of the aldosterone as a result to the angiotensin II mechanism. Now, talking about, so that is part of our correct option. What about the second option? Administer non-steroidal anti-inflammatory drugs for pain. Is this appropriate? No. Remember that I mentioned something about the NSAID as a nephrotoxic agent, and another effect is that it can cause some bleeding tendency. It has an antiplatelet characteristic. So it could comprise aspirin, or it could be the ibuprofen. And so it's not really specific to what medication here. So aspirin is going to be included here, and it has an antiplatelet property, so it could possibly lead to bleeding. And also the medication, it's because it is nephrotoxic. Okay, so those are the main reasons there. So we are going to eliminate this option. What about the next option? Provide bed rest if cyst, rupture, and bleeding occurs. Okay, what do you think? Yes, that is one of the interventions. The reason that it's correct is because of the word, or yes, if the cyst rupture. If there was no if in it, if you're just going to provide bed rest, without reasoning, then this will make this option wrong, okay? Because we don't have any clue at all in the scenario that there is an impending rupture of the kidney cyst, okay? So the word if really mattered in this option, okay? Now, we are going to select that as one of the answers, and then prepare for percutaneous cyst puncture. Remember that this is a procedure, right, that is going to be done, especially for those patients that has increasing pain because of the swelling of the kidney, because of the fluid collection. We are gonna drain those cysts, and by preparing them to go into this procedure, percutaneous cyst puncture, and in order to drain for that cyst, okay? All right, now we are going to look into offer genetic counseling. Yes, that's one of the nursing interventions. And again, this will really prepare the patient and their family to understand the possible inheritance of the disorder, because it's an autosomal dominant dominant PKD. Now, take a look on the next option, administer tolvaptan. Remember about the medication that it is indicated to block the effect of the vasopressin or the antidiuretic hormone. And this is to decrease the formation of the CAM, okay? And this can also slow down the progression of the ADPKD. And that's why this is one of our possible interventions, okay? Now take a look into the next option, monitor for gross hematuria. This is also correct because this is possibly going to indicate if there is now visible bleeding in the urine, if there is now blood tinge into the color of the urine, this is going to signal maybe there is now a cyst rupture. So we are definitely going to prepare the patient for a possible nephrectomy, okay? Now, take a look into the next one. Offer psychological support, of course. We are going to include that. Also to make sure that our patient will be assisted in order for them to cope well with the impact of the disease process. Another thing is to prepare the patient for nephrectomy. Do you think that the nephrectomy is really indicated this time? Do we? All right, do we have to select this? Is there an urgent need for us to prepare the patient? Not quite. So we are going to eliminate that one. There is no indication, okay? Because when you're talking about preparing for nephrectomy, this simply means about preparing them for having them to sign the consent, also preparing them for the NPO state, make sure that they are already aware of the surgical procedure that needs to be done by the surgeon. We don't have that in the data. So that is wrong. And lastly, increase hydration to 3 liters. Remember that we are wanting to promote hydration at this point to counteract the effects of the antidiuretic hormone. Because if the person will be deprived from taking anything orally or IV, if there is dehydration or let's say restriction of the fluid intake, then the body will have that thirst mechanism. And when this happens, it can cause the release of the antidiuretic hormone from the posterior pituitary gland, and it will lead to the synthesis of the CAM, which will now cause more cysts to form and also the buildup of those fluids into those cysts, okay? So basically our increase of fluid intake into this patient plus the administration of tolvaptan really has quite similar effect to the body, okay? So going back into the scenario here, we really want to make sure that you are reading the test question carefully, understand what it is asking for. So again, you have to really pay attention that we are being asked about the autosomal dominant polycystic kidney disease, and the appropriate nursing interventions. Okay. Now, another key strategy here for you to answer is that we're going to have to eliminate those obviously incorrect options all the time. If it is contradictory to the care, if it is going to harm the patient, if it's not really needed in the situation that is not really emergent, eliminate those. Okay, so that's my tip for you. And that ends my lecture. So I hope that you're able to understand the complexity of the two topics that I tackled today. And tomorrow we'll be talking about the benign prostatic hyperplasia and also the management, including the continuous bladder irrigation, which is very critical in the care of that patient. So I thank you for your time, and I hope that you learned so many into this topic, and I'll see you tomorrow. Thank you and have a great day. Bye-bye.